everyone. This has been a really, really interesting session. So I've been really, really enjoying attending all of it. And we have a great panel. We have Dr. Alicia Arbaje. She's the Director of Transitional Care Research and an Associate Professor of Medicine at Johns Hopkins. We also have we also have Dr. Rab Razzak. He's the Director of Outpatient Palliative Medicine at Johns Hopkins Medicine and an Assistant Professor of Medicine. Very active on Twitter. And we also have Dr. John Colmers. He's the Vice President of Healthcare Transformation and Strategic Planning at Johns Hopkins Medicine. He was also the Secretary of the Maryland Department of Health and Mental Hygiene previously. And then we also have Dr. Brendan Saloner. He's an Assistant Professor at Johns Hopkins Bloomberg School of Public Health. Welcome to our panel. Okay. Okay. So one of the first things that we began the workshop today talking about was how America is growing older and faster, and we have this huge demographic change coming, in which within I hope my lifetime, 20% of the population will be over age 65. Now, I remember years ago at USA Today, an editor said, "Oh, but this is great because 60 is the new 50, and we're all going to be healthy and live a really long time." And we had reporters in the room who covered obesity and diabetes and cancer and Alzheimer's, and we were dreading what the future could hold. And I was hoping each of you could talk a little bit about what some of the challenges, but opportunities as well, we'll face when we do have a much larger aging population. Dr. Saloner?
Sure. So I have the opportunity to wear the public health hat here. And if you look at the national data, really taking a step back, you'll see that over the last 30 years, we've made incredible progress on some of the things that have allowed us to potentially experience these longevity gains. Tremendous reductions in smoking, which is one of the biggest risk factors for premature mortality. But you do have these increases in obesity, and in the last 2 years, declines in life expectancy. And a lot of that, to the issue that I'm most interested in, stems directly from drug addiction and drug overdose and people dying earlier. And one of the points that I was making before we came up to the stage today is that when we look at the current addiction epidemic, and especially the tremendous rates of opioid overdose, even if we get those numbers to start coming down, which I think is possible, but it's not going to happen in any kind of magical way overnight, we're still going to be left with these large cohorts of people who may need lifelong treatment. So thinking about sort of the complexifying demographics and the things that are going to be changing for older adults, we're going to sort of see the long-term ripple effects of what this addiction crisis is going to be doing in terms of changing people's long-term need for treatment alongside an epidemic of chronic pain in the United States.
So could we have 80-year-olds on methadone?
Absolutely. We have 80-year-olds on methadone. In fact, people who came back from the Vietnam War, those were the first cohorts, and a lot of those folks are still in methadone maintenance programs and doing fantastically. So we have a treatable illness, but we also have an illness that presents with all kinds of other comorbidities and all kinds of other challenges. And if we don't start thinking about this in a more forward-looking way, really looking into the future, we're going to miss the boat and not help these folks to live the best lives that they can.
Wow, that's shocking. Dr. Colmers?
Well, first of all, Liz, I want to thank you for giving me a doctorate degree. I've waited a long time for that. I always appreciate getting these honorary degrees. I'm not a physician. I'm not a Ph.D. That would be my father, my grandfather, my grandmother, my brother, my mother. But
That's hilarious.
You know, there's got to be a black sheep in the
You
family.
slacked off and
I
became
know.
Health Secretary of Maryland.
I know, nothing going on. You know, I'm struck by the fact that we are talking about this change in the demography and what that impact is going to have on the individuals who are facing that. And as somebody who is a baby boomer and seeing it firsthand, the challenges, at the same time that we just heard about being at the forefront of some remarkable advances in medical science. I think the fundamental challenge for us is not just for the elderly, but for as a society as a whole. We have reached, in my opinion, a tipping point in the cost of health care. And it is not simply because the government can't afford it, because we can't afford the impact on the trust funds or on state budgets. Those are certainly very, very real issues. I think it is now fundamentally hitting home to individual families in the country. If you look at what the median household income is, and you compare that to what we have as the per capita spend on health care, there is a complete disconnect. And with, as Dr. Miller addressed earlier, there's an increasing number of individuals who are facing much higher out-of-pocket payments. As a society and as members of the healthcare field, we have to come up with better ways of pricing and producing results for the population. So to me, the challenge is how do we address that as quickly as we can. I think some of it will be driven by public health activities, certainly raising the price of cigarettes had a profound impact on the number of people smoking. So there are public health activities that can take place, but I think there are better ways in which we can organize and deliver care to people that are much more effective in relying on, increasingly relying on primary care, making sure that the barriers that we create in transitions of care are reduced, and changing the way we incentivize the provider system today. We continue to live in a fee-for-service environment where the more you do, the more you get paid, instead of the better you do, the better you get paid. And that has to fundamentally change. And I think we're seeing instances of that happening, but to me that's really ultimately going to be the challenge for this next several years going forward.
And Dr. Razzak?
Yeah, so as a palliative care doc, I take care of people with very serious illnesses, from cancer to heart failure to COPD, dementia, and so that population will certainly increase. And I think the challenge actually will be not only how do we care for them, but who's involved in the conversation. So currently within Maryland, we've got, with the global budget revenue, people are actually trying to think outside the box. You've got hospitals and health systems and payers and providers all working together to find some answers. So I think there's great opportunity there. I think what we need to do is recognize it's not only going to be doctors who sort of do the work and nurses. I think we need to really look at holistically at people and look at the psychosocial dynamics that people undergo through and how we can address some of those needs, some of the spiritual needs that people have that we don't always address. And so from a health system standpoint, I think there's going to be more that needs to be done, and taking things further upstream to not only outside the hospital, but to clinics, to people's homes. So the old model of the doctors going to your house, that's starting to come back, and hopefully we'll see that very soon in palliative care also.
Dr. Arbaje?
Yeah, so I'm a geriatrician, and I became a geriatrician because I saw the care my grandmother received when I was growing up in rural Kansas, and the care she possibly could have received had she had access to a really great team of geriatricians and nurses and people meeting her spiritual needs. I think we have an opportunity to, with the aging of America, to really see improvement in two areas and to create a paradigm shift in the way two things about our health, the two areas of our healthcare system. So one, where care is delivered. You mentioned a little bit of that already. I think that with the growing population with multiple chronic conditions, lots of medications, lots of specialists, lots of needs, we're going to see more of a need to care for people where they receive the majority of their health care, which is in their homes. And that is the most understudied healthcare setting that we have. It's the place where I do most of my research, to really try to understand how can we best deliver care in home environments, because that's where people want to be. Can we deliver hospital-level care in the home environment? And I think this demographic shift is going to really push us to think about how can we really deliver excellent care where people want it the most. The second area, I think, where we have opportunity is in how we deliver care. So the first was where, and the second is how. And some of our colleagues here have already mentioned this, but the idea is that we need to have a paradigm shift in thinking about how to deliver care that's safe, that's patient-centered, and is targeted to the goals of that patient and their families, and not sort of centered around healthcare providers and additional medications and additional tests and procedures, but really focusing on what is important for that person given where they are in their lives and what they want to achieve. And I think if we're going to be doing that in the home environment, and we're going to be doing it in a safe way, that's going to require paradigm shifts in the way we pay for healthcare, the way we deliver it, and I think that's a great opportunity that we're facing now.
Well, home care is something I've thought a lot about in my own life. My parents are elderly, and last summer, my dad, who's had he had 3 ER visits last year, and it seemed like he and my mom, as his caregiver, weren't getting the care they need. They were getting care that Medicare would pay for. So so he had 2 X-rays in 1 week. Well, they said we should repeat the X-ray. Well, now they want to repeat the MRI. And I guess he got all this expensive care because Medicare would pay for it. And what they really could have helped with is the reason he kept going to the emergency room is the caregiving issue, and he kept falling. And I guess Medicare doesn't pay for home health care aides. I think they had to pay for that out of their pocket. Can any of the policy folks or the people who treat older people talk about how do we need to change our system to pay for what people really need and will help them the most?
Yeah, it's a big question. I look at the sort of the current payment reorganization models that are out in the water now, and there's a lot of different flavors of them. I think the consistent theme is that they're doing stuff. It's just that they're not doing as much of the stuff that we want them to do. Accountable care organizations, sort of the centerpiece of a lot of the value-based payment in the Affordable Care Act, should be a kind of a vehicle for getting better coordinated care and doing things like reducing readmission rates. Some of that has happened. If you look at the evidence, ACOs have been effective at it. Not dramatic effect sizes and not sort of huge changes on the total cost of care, which, as to pick up a theme from the last panel, that also impacts consumers through the bottom line of how this, affects household budgets. So, it's inspirational to hear physicians who really have a vision for how to do this, but then getting payers to really kind of reorganize systems and to let the money flow to where it needs to go in order to get the care that patients need, I think is a challenge that's only been incompletely conceptualized and incompletely executed on. And drawing the boundaries of what medical care is, which is, I think, another theme that we've been talking a little bit about. In its aspiration, I think, is a great idea. But again, sort of, health insurers don't typically have as their business line paying for social determinants of health. Home health aides, yes, sort of paying for other things like the air conditioner that could have kept someone from going to the hospital if they had, a cooler living environment. These are things that I think are theoretically possible, but not a lot of great models about how to do them.
My favorite medical show is actually called Midwife because it's such a great public health show. And of course, that's all about home visiting. Is that, I know that's different, that's England and national health care and socialism, but is there any sort of economic model? Because it seems like those X-rays and the ER visits and the MRIs that my dad got, if I just think about the unnecessary care, if we could have saved the unnecessary care, he could have gotten a lot of visits from a home health aide or to take the caregiver burden off my mom. I don't know, does anyone think like that? Like how an MRI, like get rid of the MRI and bring in the nurse? Or?
So I think people think about it all the time, and I think the problem is allowing for the type of experimentation and demonstrations to flourish. And it does require fundamentally shifting where the money is going and how it is being spent. Under the current model, the model that has largely been in place since the mid-1960s, it continues to be largely on a fee-for-service basis. You do something, you get paid for that something. And since we're talking about Medicare here, we're talking about the elderly population, I think we need to encourage the federal government to do and try out different models. This is a big country. It's not likely that you're going to be able to develop something that's going to be applicable across the entire country easily. I am a big fan of state-based innovations that live within a federal model, and I think there should be different models that are put forward. Accountable care organizations are there. I have my own concerns about how they are designed, and we could spend a fair amount of time talking about that. But I think that there are other models that ought to be designed and tested. And I think having the Center for Medicare and Medicaid Innovation, to me, is one of the most important parts of the Affordable Care Act, and was one that, while I was worried about a lot of things associated with the potential demise of the ACA, that was one in particular, because we need to spend time and energy figuring out how to redesign how we pay for care and re-incentivize folks, and we don't have an answer today. Medicare Advantage by itself is not the answer. 30% of the Medicare population is in it, 70% is not. Most people are in unmanaged care. In Maryland, Medicare Advantage penetration is only at 12%. So we have to look at different ways of doing that, and I think one of the things that we ought to be encouraging more are state innovation models that would allow that. What would work in Maryland may not work in Indiana or in Wisconsin, but people in Wisconsin and Indiana may have some pretty good ideas about how they can do things, and we can learn from that.
I'll just add that somebody earlier said something about how taxpayer dollars pay for a lot of the innovation that starts the drug delivery or design process. So if you think about it, what we really need to be doing is putting also a lot of more additional funding into how to study what you just said, to deliver, how we deliver care. The NIH is primarily focused on particular disease states and particular body parts, particular disease states, and finding cures. But there really isn't funding allocated towards improving the delivery of care. That's been relegated primarily to the Agency for Healthcare Research and Quality, which is the least funded of the institutes that focus on improving our health in this country. So taxpayer dollars, really thinking about, there should really be some outrage around the fact that we don't have a lot of resources dedicated as a nation to look at how to best deliver care. Exactly the kinds of things that you're talking about, both at the federal level and maybe even at the state level. So I think that's a point that is worth really thinking about. How do we want to allocate our funding to try to improve the health care for the people in our country?
And I think from your question earlier about what are we doing outside the hospital. So with over at Hopkins, we do have J-Home.
Yes.
That I believe you're very involved with.
Yes. So you asked, are there even models that are in place? So at Johns Hopkins Medicine, we have the J-Home program, which started out in geriatric medicine, because house calls and going to see people at home is not a new idea, right? This is how medicine used to be practiced. People would go into people's homes and see how they were doing. It wasn't until after industrialization that people now came to facilities to be cared for. So we're really trying to bring that back and meet patients where they are. So out of the geriatrics practice, it's now expanded throughout, and others can probably speak to how far it's expanded. But really going to see people in their homes, sending nurses, social workers, doctors to come see people where they are and deliver medical care there, draw your blood there, get your tests done there if they're needed, and have a good conversation with patients and families about whether you need that MRI. Is that in line with what we want to achieve here, or do we want to achieve something else? So we do have models in place that can start looking at that.
And I want to add, I do think it's important that we be careful as we design and look at these things, that we don't have too simple-minded an approach to evaluation on things. So, for example, I worry a lot about making sure that we are protecting the type of innovation in clinical care and discovery that is important at Hopkins. I think those innovations are going to continue to be of value to us. It's going to be important for us in academic centers to be able to train that next generation. So to the point just made, we have to be able to demonstrate that we are being good stewards of care, and while our unit costs may be high, if we are only performing the back surgery that needs to be performed, while it may be expensive for that particular case, overall it is a much better approach. The unnecessary back surgery is the most expensive back surgery. So the unnecessary MRI is the most expensive MRI. On a unit basis, it may be inexpensive. So we have to realign how we think and evaluate the effectiveness of systems. And we have to do so in a way that we are careful not to create unintended consequences, particularly as it relates to the funding that's necessary for the type of basic research that much of the discussion today was centered around.
Well, when we were talking about this huge demographic shift with older people living longer, with people living longer and older people making up a much larger percentage of the American population, I have to think about some of the really huge health issues that we're facing in the United States. I mean, we're not really a healthy country. A third of us are obese and 2/3 of us are at an unhealthy weight. How is that going to affect people as they age? I imagine it's not going to make aging any easier.
And why are you looking at me when you
I'm on Weight Watchers, so I am there with you in the struggle.
Well, I might start. I mean, we think of most chronic illnesses as having a basis in inflammation, and obesity is yet another inflammatory condition and is the basis, or at least a major contributing factor for heart disease, cancer, diabetes, maybe even other diseases we don't even think of, like depression and other diseases that we may not think of as having a relationship with diet and lifestyle choices. So I think the obesity epidemic is a sign of kind of how our lives are being led, right, and how we are in need of social structures to help us be more active, have more access to great food, manage our stress better, and get more sleep. But it's also a cause of a lot of the challenges that we're facing. Diabetes, heart disease, for example, those two illnesses with appropriate lifestyle changes, and by appropriate I mean aggressive lifestyle changes, I hear you, they're hard, are pretty much preventable and possibly reversible. And so I think it's another opportunity, this not opioid, that is another opportunity, but obesity epidemic is an opportunity for us to also rethink how are we treating these conditions that are primarily lifestyle-based.
And if we're thinking about how are people living longer, so if we look at areas of the world where people are living longer, like the blue zones, what's happening there? People actually have a community. Majority of the meals are plant-based. There's activity.
Did you say the blue zone?
Blue zones, yes.
What is that?
So
Talk about the blue zones.
So there's actually 5 places around the world that actually naturally have a very high older adult population. People living into their hundreds. And there's one area in the United States, it's Loma Linda, in the Seventh-day Adventist population there, where there's a high concentration of older adults. There's somewhere in Japan, Italy, Greece, and I think somewhere in Costa Rica.
Costa Rica, I think.
And those three issues where people actually have a community, where they're actually a healthier diet, which is mostly plant-based, and number 3 is there's community that does activity together. And now there's actually a Blue Zone project in the States that are developing to create areas like that. So I think we're going to need those type of projects to really flourish to see a difference. But I think, so beyond that, I think once we sort of change the way we function as a society, I think if we look at healthcare itself, if we change payment structures and and then work on things like communication. So, doctors and nurses have limited time with patients, right? Especially doctors, right? And so if we change the way that's done, if primary care doctors are spending 15 minutes with each patient, how are they going to be able to talk about the lifestyle changes? And on top of that, now that doctors have a specific way of communicating, we're going to have to retrain them on how to communicate, on recognizing, these are your goals. These are some treatment options. Let's try to find something to meet those goals. So redesigning how doctors and nurses and other healthcare professionals are taught to communicate would be also very important.
Well, speaking of a need to redesign, when we were talking before this panel, you had mentioned the opioid epidemic, the two big O's, obesity and opioids, and how that was kind of a symptom of the way our care system was set up and the way that doctors prescribe too many opioids. Can you talk a little bit about that? It was really interesting.
Sure. So, there's a narrative out there right now, which I think is correct but not complete, that the opioid crisis stems from the overprescribing of opioid pharmaceuticals. And it's correct because a lot of people who now especially have transitioned to using heroin and injecting fentanyl started off as pain patients. I think that it's also a potentially tricky narrative because we run the risk right now of completely cutting off access to opioid pain medications for patients who need them, and also not really taking seriously the issues of chronic pain that a lot of patients are really encountering. So, as I said in my earlier remarks, we have an epidemic of chronic pain in this country, and thinking about how to sort of leverage the health system to deal with that, I think has to bring to the table a whole different set of strategies than what payers are used to sort of thinking about. Opioids are cheap medications. For a long time, they sort of came under the radar because the payers were not seeing them as a real threat to their sort of the way that they did business. I think now we're really walking that back and saying, oh, we've got to change this. It's not a bad idea to put in place tight prescription controls, especially for patients who might be naive to opioids and could really benefit from some alternatives. But there's a whole population out there of people who are chronically opioid users, who have addiction or dependence issues, but also have pain needs that really need to be managed. And sort of thinking about how to change the way that we care for those patients, I think is going to have to involve looking at solutions like acupuncture, physical therapy, weight loss, and changing exercise and diet for patients who might be overweight. These are not easy things to do, and they're probably not things that a lot of payers are enthusiastic about doing because they take a while to really be effective. But I think it speaks to the complexity of this need.
It does seem like we were talking about how in so many instances it's quick and easy if you have 15 minutes with a patient to prescribe an antidepressant or a statin, I guess, or an opioid. But there's less willingness among payers. If someone wants physical therapy, the copay for that might be more, or there might be a limited number. If someone needs cognitive behavioral therapy for insomnia, it's much cheaper to give them generic Ambien, but they might not get any coverage for the cognitive behavioral therapy to change something maybe lifelong. So, you guys deal with policy and payers. Is there a way to get around that reluctance to fund non-drug options?
I'll let John offer his thoughts. I think that it's really tricky in part because insurers think about their losses on a year-to-year basis, and a lot of times people are transient through insurance plans. So getting them to sort of take the long-run perspective on their populations and do population health management is difficult. And then you sort of compound that with what I think has also been a theme of this panel, that a lot of the solutions sort of are at the interface of social systems and healthcare systems, and sort of getting health systems enthusiastic about engaging with social systems is really tricky. I see this a lot in the context of substance use treatment, where there's a lot of things we could be doing for people that are not within the kind of, they're not cleanly in the arena of medical care, but they could make a huge difference in people's lives. So how do you get sort of models of delivery that bridge those different systems?
And yet Medicare is one of those systems where you could be getting a Medicare card for 30 years potentially. So I don't know, is Medicare any more amenable to seeing their patients as long-term clients, long-term customers?
So again, I go back to my point being that we need to develop new payment models and test them and allow Medicare, encourage Medicare to develop them. CMMI has $10 billion available to fund innovation and demonstrations, and I think that while that sounds like a lot of money, relative to the trillions of dollars that we spend on in healthcare, it is to a degree a drop in the bucket. And these new models can show promise. I do know in Maryland, under our global budget arrangement, we're beginning to see a bending of that curve. We're beginning to see provider organizations who now have some concept of holding down total cost of care, or at the very least hospital spending in aggregate, are reaching out and finding partnerships that previously they didn't. In parts of Western Maryland, health system out there is working to engage the public health department in ways that they had not historically, or working with the school-based health clinics to make sure kids are staying on their asthma medication, because all of a sudden that additional emergency room visit for a child with asthma is no longer a good thing for the hospital. That additional volume is not something they want to see, and I think that's really what we need to change. The way in which we remain in silos and the money in everybody's pocket has historically been kept there. We have to figure out better ways of encouraging the type of coordinated care that ultimately is focused on the patient.
And when we talk about healthcare, the IHI talked about the triple aim, reducing cost, improving population health. Third is caregiver experience. Now they're looking at this fourth aim of care team well-being. So making sure we're able to take care of ourselves, so we can actually take care of the patients that we serve. So I think that's going to be another key factor in this whole healthcare discussion.
And hopefully there'll be enough caregivers to cover this huge demographic bulge. I know I'm in Generation X, and that was a smaller generation, and yet I guess my peers will be the ones taking care of the baby boomers, which was a massive generation.
Make sure you're exercising.
We joked before this panel that I don't know what the question is, but the answer to everything is exercise.
Yeah,
That's the take-home point that we learned today. We have maybe 10, 15 minutes left, and I don't know if we have any questions, because this is a great and very large panel, if you'd like to ask them.
One there.
Hi, I'm Susan Jaffe. I cover Medicare for Kaiser Health News. There's two things I'd like to add. Number one, Medicare does cover home health care indefinitely if you need intermittent skilled care. I recently wrote about this, and turns out that there's various disincentives and pitfalls in terms of getting this coverage, but it is on the books. If you need physical therapy at the home, if you need someone, changing your wound bandages, things like that, you're also entitled to a personal care attendant. Also, number two, we talked about changing how we deliver care. You may know that Hopkins has a PACE site. PACE stands for Program for All-Inclusive Care for the Elderly. There's currently, and basically it's everything under one roof. for people who, they must be nursing home eligible, over 55, have major, multiple chronic illness, and there's an interdisciplinary team at each of these sites. There's now about 250. I did some research here while I was waiting. There's about 45,000 people across the country who participate in this program, which when you think about it is almost nothing. And they get transportation. It's an adult daycare program. It provides meals. It provides recreation. It provides all medical care, including dental. And each person has what's called this interdisciplinary care team. It includes a social worker, RNs, doctors, even the van driver. Anybody who has any contact with seniors during the day can participate. When I visited a couple of years ago, I talked to a man who told me that it was the van driver who told his doctor that he just didn't seem like himself. He was very quiet, kind of depressed. Take a look at him. Turns out that he had some type of cancer, which they were able to catch because everybody was, there was sort of this village of caregivers. And because they are reimbursed by Medicare, it's actually a Medicare Advantage plan, but they have waivers so that they are allowed to provide things that Medicare and Medicaid don't normally provide, that address sort of the social determinants of health, like an air conditioner, like flea treatments for the dog so that this person doesn't keep getting flea bites, mattresses, et cetera. So ramps and to the home and grab bars in the bathroom. It's interesting that Virginia now has 12 PACE sites. DC has 0. And Maryland, it still has 1.
Thank you for bringing that up. You are such a great advocate for what I think is the best way to deliver health care to older adults, and that is the PACE program. At Hopkins, it's called Hopkins Elder Plus. We're the only one in the state of Maryland, which is another, I think you made that point very clearly. You wonder why that is. It came out of Chinatown in San Francisco, Chinese families feeling that they wanted their elders to have better care than they were getting. And so it started there. I don't know how long ago, but I think a couple of decades at least. And it's really now grown into this program. I want to also comment on your second point, which is home health care. You're right, you can get intermittent care through the Medicare home health care benefit. And it's vastly underutilized, actually, for the most part, by physicians and who are in the outpatient setting and in the inpatient setting. My research is completely focused on that healthcare setting because that's the healthcare setting that has the most readmissions and the most adverse events. And it's not because they're getting poor care. It's because it's a population, actually, that's understudied. People who go home and need home health care services, so PT, OT, and those kinds of services are at higher risk for reasons that were not quite clear, more than the nursing home population, more than the rehab population. And so I've made it my research work to understand what's going on there and how can we actually deliver care better in that home environment to really reduce the care. But please advocate for you and your loved ones when you go and receive care for your older adult that ask, hey, could we get home health? Are we eligible? And most people usually are if they're homebound, meaning they don't get in and out of their house very much. And this is the Medicare population we're talking about. And if they've had any kind of change in diagnosis or need wound care or have had a medication change. So it's vastly underutilized, and it's another model that we need to continue to propagate.
It's underutilized because physicians and caregivers and patients don't know about it.
But
you're right.
my understanding is you do
Medicare
have to be.
doesn't explain why.
My understanding was you do have to be homebound. That
Yes.
someone who has Alzheimer's, for example, but is still ambulatory and in fact wanders would not be eligible.
I think they would. Well, so the technical definition of homebound is really funny because it's a little bit under interpretation. It has to require a quote-unquote taxing effort to leave your home, and that can be due to cognitive impairment. So someone with Alzheimer's should be considered homebound unless they're very, very functional. But it means you're allowed to go to the grocery. No, you're allowed to go to your place of worship and the doctor, and maybe to get your hair cut, I think. And if you can independently go to those places, you can still be considered homebound, so long as it takes effort to get to other places.
It's very different from bedbound.
Yeah, it's not bedbound. It just means you can't get out of your home easily without the help of someone else.
Did we have another question?
Globe 1234. There have been a couple of JAMA articles recently on that Americans don't use more care than other countries. We just pay a lot more for it. So I wanted to ask what Hopkins is doing to train more providers at lower cost.
Well, most of the research shows, I think it still holds true, that when you do, and it is not an easy thing to do international comparisons to begin with, but most of the difference, as I understand it, has to do with price, not with utilization. And I think it is to that point that we have been talking about how do we restructure the system in ways that recognize that. It's not utilization per se, it is price.
It looks like we have a question
Hi,
here.
Shannon from M.P.H today. Dr. Saloner, I had a question for you. You mentioned things in terms of treating people who have a pain issue, but also potentially a dependency or an addiction issue. I think you were talking about that population in terms of things that don't fall cleanly in the medical system, aren't considered necessarily medical care that could be used. Can you give some examples of what you were thinking of there?
Sure. So I think I was making a point about addiction care more broadly.
Okay.
So there's a lot of, if you think about starting a care process for a person with a substance use problem, there's things that you can do that are more clinical in their orientation, like providing them with evidence-based medications and counseling. But there's a whole range of other things that we have pretty good evidence help people in their recovery that aren't really medical services. So providing them with vocational support, providing them with housing assistance. For the populations I'm interested in, helping parents to gain parenting skills. People who are in the criminal justice system. I mean, this is like the single largest missed opportunity is people who sort of fall between the justice system and the medical system, and there's just complete lack of coordination between those two arenas. So I think that's really the point that I was making on that.
Okay, so I have a second question on the dependency versus addiction piece.
Mm-hmm.
I've heard numerous, radio podcasts and read articles just about this idea of people having to accept pain.
Mm-hmm.
Is that something that you think, should the threshold for pain be changing because of this dynamic, or because patients may be too dependent on pain medication? Where do you fall in that?
I think it's important to recognize that pain is a significant and impairing experience for patients, and to not try to steer away from that. And I think that there's pretty interesting data out there about how things can go better for patients when there's clear communication from their provider about pain that's expected and sort of normal as part of a recovery process. I'm especially talking about like in the context of a surgery. I think another aspect of this where there's really been some important work has been in emphasizing regaining functioning as a sort of alternative to just reducing pain. Mm-hmm. A lot of patients have that goal of improving their functional status. And so when you kind of have that orientation, it leads you to a different set of rehabilitative services.
Thank you.
Well, I think we're out of time, but this has been a terrific panel, and I just want to thank all of you for what a great discussion, and thank you for your questions.